So today we are going to talk about scaling and root planing. Yay! So SRPs, which are most commonly and colloquially known as deep cleanings, right? When we're explaining to patients, it's one of the most important treatments that we provide to treat periodontal disease.
Yeah, it helps stop infection below the gum line, it reduces bone loss, and it prevents teeth from becoming loose or lost.
So, but this is a billing podcast, right? So there's a disconnect that we see very, very often with what the dentist says is clinically necessary and what an insurance carrier will pay based on coverage criteria that is often, like those things are often like completely different.
And this disconnect is often not acknowledged or, most importantly, not even communicated to the patient. So patients get treatment that they need, the office does its job, but then the denial arrives and everybody feels blindsided.
So that's what we're going to talk about today, how SRPs are critical for stopping bone loss and saving teeth. And if your patient is expecting coverage only to get a surprise bill because the criteria wasn't met, that's chaos. So we're going to try to fix it today.
Welcome to the Truth Decay Podcast, talking dollars and cents with Sara Baker and LaRae McMullen.
So let's start with the basics. SRPs are not optional hygiene procedures, right? SRPs are typically recommended for patients with periodontitis, and it's to reduce pocket depth, stop disease progression, and manage inflammation. It's rarely recommended for simple gingivitis without like pockets or bone loss.
Doctors make that decision based on periodontal findings. Here's the key: general indications for diagnosing SRP. These are not required for a diagnosis, and you or your dentist might absolutely recommend SRPs for some other clinical reason, but these are the common findings. Number one would be periodontal pockets. So we're talking about pockets that measure 4 millimeters to 6 millimeters, which would probably be considered moderate, or 7 millimeter pockets, which are considered severe, and even sometimes potentially they can require surgery.
So exactly. And another key indicator that might have a doctor diagnose the necessity of SRPs would be radiographic evidence, right? So specifically signs of bone loss in x-rays, but it's worth pointing out here for the context of our conversation that this is not actually a requirement for saying that SRPs are necessary. Like, in fact, honestly, SRPs are supposed to stop the progression of periodontal disease and hopefully prevent there being bone loss in those x-rays, right? That's actually part of the problem with this disconnect that we see between insurance criteria and then the diagnosed need for SRPs. Yeah. So that's like part of the issue. Third key indicator would be clinical symptoms, right? So things like persistent bleeding gums, red or swollen gingiva, persistent bad breath, recession, and loss of attachment. Again, billing podcast, pro tip, it is super important that things like bleeding and loss of attachment be noted on the perio charting. Yes, like we actually don't see that all that often. A lot of times when we get perio charting to bill with periodontal procedures, a lot of times it only has pockets. And if there is bleeding, if there is loss of attachment, like you noting that on the perio charting potentially could be the difference between being able to meet that criteria from insurance and not. So please note that stuff on your perio charting.
Okay, and our fourth key indicator is calculus buildup. So when there's a detection of subgingival tartar and calculus. And then number 5 would be failed conventional hygiene. So that's really kind of when a routine dental prophylaxis isn't really, it's found to be insufficient. It's not really like what you need to make sure that you're, all cleaned up to stop that progression of gum disease.
Yeah. And again, like we're billers, we are not clinicians, even though we're talking a bunch of clinical stuff. And since this is about billing, this is going to sound silly, but like one thing that we do also want to point out is it's really important to use the correct code when you are, doing things like posting the treatment you've done or even pre-estimates, if that's the route that you want to go. D4341 is a full quad, so it's 4 plus teeth, right? 4342 is 1 to 3 teeth. So if you are specifically targeting, like, again, as always, post what you actually do. But if you're doing only 1 through 3 teeth, post 1 through 3 teeth, and like be aware too, that we're going to go into this a little later, but like that code could be changed on you based on the clinical criteria of the insurance carrier. But like post what you did. That's really important.
Yeah, so like kind of, if you did 1 to 3, post 1 to 3. If you did 4, post 4, and post the whole quad. But the criteria for the insurance is looking to see that in the perio chart. So if you did 4 teeth because you felt like it, but the criteria was only on 3, that's kind of what we're talking about here. So not only is it just inaccurate to use those wrong codes, but it might result in downgrades and fee discrepancies, which again, we're coming from that billing perspective. So that'll create issues with posted fees and what you estimated and what you collected that is going to be the patient portion.
Yeah, so all of that being said, like here's the billing issue with SRPs. And this is the reason we wanted to talk about this today. Clinical necessity does not equal insurance criteria for remitting payment, like period. So that's where things fall apart for most offices and where we see the most issues.
Right. In order to qualify for any kind of payment toward treatment, the insurance carriers often require a specific documented evidence in order to allow that payment. So this criteria can range from bone loss on radiographs, loss of attachments, certain depth thresholds, all the way to detailed bleeding points.
So you can have, like the doctor can have a strong, valid clinical reason for diagnosing SRPs, one of those key indicators that we talked about earlier, right? Like a doctor might see one of those and think this patient really needs SRPs. That's the best treatment for this patient. Deep pockets, bleeding, inflammation, and still that treatment is potentially going to get denied by the carrier.
Right.
If the carrier's particular criteria wasn't met. Like an example that we see like really often is a carrier might require, in order to remit payment on SRPs, they may require 4+ millimeter pockets, evidence of bone loss in those radiographs.
That's a big one, yeah.
And documented loss of attachment. So if the patient has everything but documented bone loss, boom, no qualification, no pay from insurance, like period.
Yeah. It's a very important thing that we want everyone to know is that a denial for payment is not saying that the treatment wasn't appropriate. It's just how that payer, like, it's how their criteria work. So just because they're not paying it doesn't mean that they don't even maybe agree that that's what they would have done. It's just not what the criteria is for that insurance plan.
But a lot of offices, like with the way that they talk about billing insurance, or like really honestly, a lack of communication at all about the potential that a patient is going to owe something for this treatment. Like you just said, devaluing that treatment, right? They're not even talking about the value a lot. They're just saying, here's what's been diagnosed and here's what your insurance is potentially going to pay, right? And that part where they're accidentally conflating in like coverage criteria as the same as clinical necessity, right? This doesn't just happen with SRPs. This happens with all treatment, but specifically for this conversation, right? That's where the miscommunication and the devaluing of that treatment and surprise patient portions, that's where it begins.
Yeah. And if you center the conversation around insurance coverage, then when coverage goes sideways, the patient feels blindsided. So instead, you really should center that conversation around what treatment is needed.
Yes, like 100%. This is our message. If you center treatment-based conversations around care, right? Mm-hmm. Explain why the SRP is needed and that insurance may not cover based on their criteria, right? Like explain all that. You've already set up an expectation.
Yeah, 100%. So, okay, let's talk about some specifics. Some common criteria that carriers often demand. They include probing depths that are not deep enough, no visible bone loss, like Sara mentioned earlier, no documented loss of attachment, and then that bleeding record not being filled out or no bleeding at all.
Yes. So this is an important part, right? if your periodontal charting doesn't clearly capture the bleeding, the attachment loss, the bone levels, right? Like we've said, that's a denial waiting to happen when you're already kind of being in some ways set up for failure, we would argue. I mean, like, again, we don't work for insurance companies. It is frustrating to have an SRP denied because there is no visible bone loss. And we're trying to prevent that by providing this treatment. That's super frustrating in itself and kind of an uphill battle that you have to climb to talk to the patient about coverage. So by not completely charting your periodontal charts, right, and putting all that stuff in there, you're setting yourself up for more denials. Like, don't 100%. Do that.
We'll come back to that documentation because this episode isn't just about the problem. It's about what you actually do each day to prevent those denials.
Yep. So, okay, perfect. So let's get tactical here, right? So step 1, patient expectation setup. You must talk early and often about potential patient responsibility and the necessity for this treatment. Like before, not after the treatment is done. That's not the time to talk about that the patient might have a bill. Like, you're going to have to talk about it before, when you're selling it, essentially.
For sure. So a script idea that you could be using to your patient would be something like, Dr. X recommends SRP here because we see insert whatever the findings were. Now, your insurance may cover this, but many carriers require specific documented criteria. So you may be responsible for part or all of your portion.
And the key here is emphasize not meeting insurance criteria does not equal lack of clinical necessity. You need this treatment. That's why we are recommending it to you. You need this treatment. So that's vital. Like, it stops patients from thinking that the doctor was wrong. I'll tell you, like, it's actually very common too, when a patient is calling about their bill, when they've been confused about their bill, sometimes they will have called the insurance carrier first. And the insurance carrier, like whatever rep they got, sometimes will use terms like they shouldn't have done this. Or, maybe the patient is even kind of picking up on something, right? They don't speak the lingo. And so they'll call us and they'll say, well, but the insurance company said you shouldn't have done it.
Right.
That's not what they mean, right? Like, they're talking about codes on certain days, or they're talking about criteria. They're not talking about the necessity of treatment. So like, the office needs to set that expectation and establish that so that the patient doesn't go get confused and now you're having to like apologize. You shouldn't have to,
Yeah. For that script, you can also add on, we estimate your patient portion to be X amount today based off of your benefits. If insurance pays more than expected, then we'll refund you. If it's less, then we'll send and you'll see in the mail a final statement. Set that expectation. It will make any further collections so much easier.
Absolutely. So step 2 is going to be documentation equals defense. So again, not just charting those pockets. That's really the bare minimum of what we see in clinical notes, on periodontal charting. Document like so thoroughly and explain what was done, why, tie it back to clinical findings, bleeding, swelling, probing, loss of attachment, and also you absolutely have to have some kind of x-ray. 4 bite wings will do in a pinch, but we really love to see current full mouth x-rays. That's better.
Yeah, for sure. Okay, so for example, you could put on there moderate generalized periodontitis with bleeding on probing of 5 to 6 millimeter, radiographic evidence of bone loss, localized attachment loss requiring debridement. This level of detail really, really matters. So you could use that little script or whatever as, your base narrative and then just add in what the findings were.
Yep. Definitely. Step 3 is going to be check your coding logic. So again, 1 through 3 teeth, 4342 versus 4 plus teeth, 4341 SRP. If you're in network, right? So your fee, if they reprocess it, if they get it and they change your 4 plus teeth to 1 through 3 teeth, right? Your fee is probably going to be adjusted based on your contractual terms, and you will have charged the too high a fee, right? Carriers are going to automatically reduce the payment, and your patient portion collected would be incorrect, right? Which
Yeah.
is going to result in potentially a credit. Which, if you have a system for maintaining your credit balance report, which we've talked about in a previous podcast, this isn't the worst thing, but like still we're trying to avoid surprises because surprises are the enemy of a billing system.
Yeah. Fun little fact, a big carrier specific detail about Delta. We call this the Delta rule. Delta only allows you to bill for 2 quads of SRPs per data service. So that means if you do more, the extra is not payable. And if you're in network, it's not even billable to the patient. That's a Delta processing policy, and there's no getting around it. You cannot appeal your way out of that one. If you are out of network, you can charge the full fee for all 3 or 4 quads that you did, but you must still educate the patient that insurance is not going to cover more than those 2 quads. Again, make it be no surprises. So, we recommend scheduling 2 quads on 2 different dates of services. If your patient is like, I absolutely don't want to do that, I want to do it all in one day, just let them know, okay, that your insurance is going to pay for 2. You're going to be, responsible for the other 2. So just no surprises, guys.
And again, like it's really important, like you said, 2 in a day. So in a situation where you have an in-network patient who's trying to insist on doing all 4, you, the dentist, are going to be doing 2 quads for free. Literally free.
Yeah.
Because you are not allowed to charge the patient for 3rd and 4th quads. So like
100%.
That's up to you. If you want to be like a super duper nice person for some reason and do 2 free quads, I guess you're doing a 2-for-1 deal, and that's great. But like Delta will not allow you to do more than 2 if you are in network. So like,
great distinction. You can
Yeah.
do 4 if you're in network. You're doing them for free because you can't bill the patient. If
That's
you're
right.
out of network, you can bill the patient.
Exactly. Yep.
Yeah.
So step 4, patient billing communication. Like we talk about this all the time, and we've even talked about it today too, but the script you use changes everything, right? Like this is so important. We want care-centered language, not coverage-centered language.
Yeah, for sure. A script, because I've been doing scripts all this episode. A script for expectations could sound something like, this treatment is important for your long-term dental health. Your insurance may not cover it, but we recommend it anyway because of XYZ. Let them know why it's recommended. And you will be financially responsible if it is not paid by insurance. Like legitimately say they owe.
Rip that Band-Aid off. Like
Yeah.
say it, right? Because the alternative of you not saying it is you set up an unrealistic expectation, and then the patient's pissed, and then you're having to discuss apologizing to the patient, a potential write-off, right? Like have that uncomfortable line that you say, and that, that's like part of what we advocate this whole damn podcast is like have that conversation so you are not apologizing and having to do reactive cleanup later, right?
Yep.
And for patients that balk at the cost, right? Because like, it's expensive. Again, like I've said a million times that patients are not necessarily turned off by dentistry being expensive. They're upset when it's a surprise, right? So if patients balk at the cost, you help them. Like we can arrange a payment plan or financing. So your oral health isn't delayed because of cost. Like that is incredibly important because again, you're centering the conversation on care and not coverage.
Yeah. Mm-hmm. Okay. And then step 5, our final step would be follow up on denials. If something is denied, you can consider appealing with new information. Don't resubmit the same documents. You have to have something new in order to appeal. So add a narrative explaining clinical urgency or bone loss or attachment loss, bleeding. But don't just throw those charts and that FMX back on there because they're not even going to take a look at that.
But know when you should not appeal, right?
Yeah.
Like if the criteria is just straight up not met, if you get a denial and the denial says nope, like must be bone loss, and there's no bone loss, it's not gonna be covered. And you hopefully should have known that at some point, right? Whether it was a pre-estimate or whether it was, just checking benefits or whatever, right? But like, don't waste your time on an appeal that is literally fruitless, right?
Yeah.
So
a waste of time, like quite literally.
Absolutely. So like our advice is, again, prep the patient for their potential financial responsibility, and like know, again, if it's going to be covered beforehand or not, like they need to understand that there is a possibility that they are going to owe something.
Yeah.
Even just laying that expectation is going to just pay you back so much
Yeah.
down the line.
Yeah, basically what we're saying is don't waste resources on pointless appeals. If it's a no pay due to not meeting criteria, then know that. Don't make your patients be confused. Be clear and direct, and do it the same way every single time.
If there's anything that you can take away from this, we want you to know that SRP denials are not a judgment on clinical necessity. It's just criteria mismatches, right? So like, don't take that personally, take it procedurally, and have systems around that concept so that you're communicating it appropriately and that you understand it too, and you're putting your time and effort in the right things.
Yeah, documentation, communication, patient expectation setup, and carrier contract rules. That is your toolkit to reduce those surprises.
Absolutely. So, LaRae, what are 2 action steps that our listeners can do right now?
I would definitely say audit your SRP charting templates, add narrative fields for bone loss, attachment loss, and bleeding, because those are the ones that we typically see on the billing side that are the 3 most common. This will make it easier to chart and make it harder to miss those super important clinical criteria.
Yes. And number 2 would be revisit your patient script. Like, do you have a patient script? Are you using it? Are you saying the same thing every time? Those are questions number 1. But emphasize necessity, possible lack of coverage, estimated patient responsibility, and use care-centered language when you are discussing these things.
Yeah. All right. So final thoughts for today, Sarah. Do you got any?
I mean, I've said it a bunch, but like, insurance criteria does not equal clinical criteria. Even that, say that to a patient, right? Insurance criteria does not equal clinical necessity. And your patients need to understand that, and they need to hear that often and early.
I would say my final thought would be documentation must tell the why and not just the what. So your narrative plus the objective data.
Yeah. Ultimately, guys, like, again, this is a theme, and we're going to have an upcoming episode on this, but care-centered language is so important, and please use it with patients all the time. Like, focus on health outcomes, not whether insurance pays, right? Because that's what they hear and that's what they focus on. So think about that when you're going forward with this. So we're going to have some downloads for you guys on the website, and it's going to involve like the kind of things to look out for with SRPs, things to prepare for. Periodontal billing is literally one of our favorite things. I've been doing billing for a periodontal office for 20 years now. So,
we know what we're talking about.
So yeah, like, please check it out. If you like what you heard today, please consider subscribing on whatever platform you are currently listening to us on. You can send us an email at hello@thetruthDecayPodcast.com, or check us out at sddentalsolutions.com. We'd love to answer your questions. We'd love to address any, thoughts that you have, or, if you hate or love SRP billing, let us know, because I love it. Yeah. So, let's talk about it. I love it. It's so weird.
All right, guys. Well, if you are on any of those social platforms, we are on LinkedIn, Sarah, myself, and SD Dental Solutions. You can find us on Instagram, and you can also find us on Facebook. So come say hi.
Yep. Love you. Thank you.
Love you. Bye.
Bye.